CHÉOS exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
And welcome, everyone. I'd like to start by saying that, I'm here in Vancouver. Today, I'm at the UBC campus, and it's the traditional and unceded lands of the Musqueam, the Squamish, and the Tsleil-Waututh nations. And we are committed to the proper stewardship of these lands going forward. I'd like to introduce our speaker today, who I've known for several years now, and she's Dr. Mary de Vera, who is an associate professor in the Faculty of Pharmaceutical Sciences. And she's also the Associate Director of Education at the Collaboration for Outcomes Research and Evaluation, CORE. And she's also a research scientist at Arthritis Research Canada. And of course, she's a research scientist at CHÉOS, the Center for Health Evaluation and Outcome Sciences. Mary is an epidemiologist and a health services researcher, and her work is to support and inform patient journeys in living with and managing chronic diseases. She's also a person with lived experience. The theme of Dr. Vera's research is Medication Matters, and her goal is to improve outcomes of medication taking a different patient population. Her title today is Data-Driven Patient-Powered Colorectal Cancer Outcomes Research. Thank you for coming and agreeing to present at our work in progress rounds, Mary. It's a pleasure to have you here and to introduce you today.
Thank you for the introduction, Aslam. And I believe I have to give 2 minutes for the poll setup. Perfect. So if I could all ask you guys to participate in the poll, and then I will, as I start to share my screen. Okay, is it okay to share my screen now? Okay. So sharing my screen. Okay, excellent. And you guys can all see my screen, okay?
Yes.
And the poll is complete. Okay, excellent. I don't know how to close it because it still looks open. Okay, so thanks, Aslam, for the introduction. And it's a true pleasure for me to be here today to present at Work in Progress seminar. I too want to take pause to acknowledge I am coming to you from my office at UBC, which is situated on traditional, ancestral, and importantly, unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And I'm recognizing that you're all joining from many different places. So I invite you to take pause and reflect on the land and the people whose land that is. So just a bit of an outline of what I hope to present today. I'm going to give a bit of background, and then I'm going to be highlighting research that I've done with colorectal cancer outcomes research. A big joke with my team is that we cannot do a study until we have a proper acronym. So these are all the names of our studies, which are like our babies. So define, explain, story, explain again. So I'm going to be like taking you through these studies over the next hour, and then talking about the next steps and where we hope to go from here. So I thought I'd start with a little bit about me. So I am a fairly new CHÉOS scientist. So I joined last year, and this is my first work in progress. But I've been with UBC for a long time. So I did my undergraduate degree and also my master's and PhD. And just to show like how long I've been here, I predate the School of Population Public Health. So when I did my training, it was still the Department of Healthcare and Epidemiology. I did do, like, I was unceremoniously kicked out of UBC to do a postdoctoral fellowship at University of Montreal in perinatal epidemiology, but I came crying back and did a second postdoc in pharmaceutical sciences. So lucky enough to have been appointed at the Faculty of Pharmaceutical Sciences since 2013. I was tenured in 2020, and then just in April, I also started a new post as an associate dean in the Faculty of Graduate and Postdoctoral Studies. So to say I love UBC, I've been here longer than I think half of my life, and I see myself being that little old lady growing old at UBC, hopefully. So the last 2 years, so when I was putting together my tenure package and also doing a renewal for my Canada Research Chair, it's really allowed me to reflect on the research that I've done and then trying to box it. So I can't help but think about the bento box. So I love Japanese food, but it's a big problem whenever I go to a Japanese restaurant and that I want to eat everything. But lucky for me, there's this wonderful thing called the bento box, which lets me do just that, like have a little bit of everything so that I really satisfy my cravings and my desires to eat. So just as I am at a Japanese restaurant where I want to eat everything, it's kind of like that in my research where I just kind of want to do everything. So again, thankfully for this concept like the bento box, I've adapted it to kind of contain and organize and describe my research. So all of this is the bento box of my research. So my goal is to support patient journeys in living with chronic diseases. And I have my objectives, which ground that work. So, and which also inform the pillars. So one pillar is treatment and adherence. And then another pillar is in health outcomes. I do a lot of this work in arthritis, which is also where I did my graduate training on. But for today, I am going to be talking about colorectal cancer. So colorectal cancer is the third most common cancer in Canada. And in 2021, the Canadian Cancer Society estimated about 24,800 Canadians were diagnosed with CRC. Historically, it has been known as a disease among older adults. So striking in those that are 50 years and older, and that's actually the target of population-based screening, where screening starts at 50 and over. But there's been overwhelming evidence in the past decade of a changing epidemiology of colorectal cancer, particularly an increased risk among younger adults, that is among under 50 years. So this is the framework that has really informed this research and then what will be informing the seminar. So when I will be referring to either CRC overall, but then I will be focusing a lot of this on young onset colorectal cancer. So that is diagnosed in adults less than 50 years. And then I will also be referring to what we call average age onset colorectal cancer, or yCRC, which is that diagnosed in greater than 50 years. And I think for those of you who have seen this work, who have followed me on social media, you know, or you probably have seen me refer to it as my passion project. And the reason that I am doing it is I was diagnosed with young onset colorectal cancer when I was 36. So this is a bit of a timeline that I actually created that just take me through the journey. So it was December 2015 when I had first symptoms. I had a colonoscopy, which confirmed the diagnosis in March 2016. And then for my treatment, I had 5 weeks of chemoradiation. And then I had surgery, which was a lower anterior resection at St. Paul's Hospital, and also an ileostomy, which is a pouch that I was outfitted with, which I use for waste. Following that, I had 4 months of chemotherapy. And then 10 months later, I had a reversal of my ileostomy. So I thought I'd start with like sharing how I went from a cancer patient to a cancer researcher. So it wasn't something that I wanted to do. And actually, in fact, one of the things I promised myself when I got diagnosed is not to go to Dr. Google and just have faith in my care team. So, and just to turn off, you know, that health research that epidemiologists had and just be a patient. So I had no intention of even going at all, touching anything cancer research. But I had a lot of like anxiety, I had a lot of worries, and I had a lot of restlessness because it's hard to go from, pushing, starting a tenure track position, then having a baby, and then suddenly life kind of stopped because then I was waiting for treatment and then I was waiting for, the response to that treatment. So I needed a space to park all of that energy and park all of that anxiety. So I started a blog called Mary Full of Grace. And I thought it'd be a way for me to, share the experience. Because one thing that I found was there was so little people around me that looked like me. When I would go to the hospital, when I go to BC Cancer, everybody looked older. So then it was really hard to see that I wasn't the only one experiencing this. So I thought with a blog, I could share some of that loneliness, some of that anxiety, but then also kind of combine it with what I know about health research and use it to like educate. So that was the blog. And then because of that blog, I also started an Instagram, which I used to start following patients like me who were diagnosed with cancer young and seeing what it's like for them. And that community has really been amazing in terms of like the encouragement, the support through the cancer treatment, and now as someone trying to do cancer research. It turns out I'm not a very good blogger. I put so much work into my blogs, but then really my main audience was my mom. And it started to stress me out when I wouldn't blog for a while, or and then she would text me and be like, hey, why haven't you blogged? Or, her one other friend who was my one other subscriber would text her to ask, why isn't Mary blogging? Is something wrong? So that was causing me stress when the blog was supposed to not stress me out. So then I decided to retire Mary Full of Grace and then really use the energy that I had and the desire to do something for the community and put the researcher back on. So, but it wasn't, again, it still wasn't an easy decision. It was an instant decision. So this is why I have to thank two people who've been really instrumental with really helping spark, that from that question to helping really support and grow it. So one of them is Dr. Larry Lin, who is also a CHÉOS scientist, who is the director of CORE and who is one of my mentors. He was the first person I asked, like, hey, Larry, I really want to try to do colorectal cancer outcomes. Can I do it? And a lot of people know I call him Uncle Larry. So Uncle Larry told me, it's like, as epidemiologists, we're really methodologists. So we can swoop into any condition. So why not do it? So he was my first yes. And then I was fortunate enough to have a meeting with Dr. Stuart Peacock over at BC Cancer. Same question, like, Stuart, this is the experience. I'm thinking about going into colorectal cancer outcomes research. Coming from a patient, am I crazy? And then God bless Stuart, he told me you would be crazy not to do it. So I have to think from those two am I crazy meetings to them really supporting and inspiring me, I really owe a lot of gratitude to Larry and Stuart. Also owe a lot of gratitude to collaborators that came on board and again, that really supported this right from the beginning. So I really want to call them all out because this would not be possible without them. So one of them being Dr. Carl Brown, who is also with CHÉOS and a colorectal surgeon at St. Paul's. So Larry introduced me to Carl and Carl said yes right away. Also have to give a shout out to Dr. Manoj Raval, who was my surgeon, who came on as well as a collaborator after he graduated me. And then when Dr. Raval said yes, I got brave enough to ask my other doctors. So Dr. Charlene Gill at BC Cancer was my medical oncologist, who also said yes, and then introduced me to Dr. John Laurie, who is also a medical oncologist at BC Cancer. And then, of course, one of the questions I had for Stuart, aside from, am I crazy, was, will you be a collaborator? And he said yes, thankfully. And then he invited his friends. who are working in colorectal cancer research. So that's Dr. Winston Chung at the University of Calgary and Dr. Calvin Chan at the University of Toronto. And then when I saw that Stuart invited his friends, I was like, well, I should invite my friends. So then I invited two of my best friends who were my classmates in grad school. So Dr. Helen McTaggart-Cowan, who brings in a lot of expertise as a longtime researcher at BC Cancer and also gives the qualitative lens to this work. And then because I'm also doing some health economics work, also invited Dr. Mohsen Sadasipavi. Sorry, that was a typo in my slides. And I think for the trainees here attending, I always tell my grad students, find your peeps in grad school, because those peeps are going to be your collaborators and co-investigators when you are an investigator. And I have to say, it is a dream come true to be able to work with two of my best friends from grad school in this research. So now that you guys know how this all happens, again, it did not happen overnight. It did not happen instantaneously. It was a long decision, a lot of reflection to see whether I should do it. I want to take you on a timeline, and this is now where I want to take you to some of the studies that we've been able to do since starting this around 2018. So fortunate enough to have received the C grant from the Center for Applied Research in Cancer Control, so ARC, and then we also received the project grant from CIHR. So I want to take pause again and then share a little bit about like some of the nomenclature they use in my research. And as I talk about these studies, I also want to honor patient partners that have really inspired, motivated, informed a lot of this work. So two patients, Sarah DeBoard and Violet Kuchar. So when I was starting this work, I was also doing a lot of just reaching out to patients that I'd already had interactions with on Instagram, again, just to get their feedback, just to get their insights, and also get some of their expertise. So Sarah actually worked at the US Colorectal Cancer Coalition, and then Violet was a huge patient advocate. So following them on social media, and then actually my last in-person conference before COVID in 2019 was a summit on young-onset colorectal cancer. So for those of you who follow people on social media and then get a chance to meet them in person, it is a treat, right? So it was a treat to meet, these people in real life. So there's a picture of me with Sarah and a picture of me with Violet. I hold these close to my heart because sadly, Violet and Sarah are no longer with us. I also hold close to my heart one of the lasting conversations that I had with them at that conference, where they basically told me that they hate the word survivor. So up until that point, I was using that word, cancer survivor. I was using it as a hashtag. I was using it to call myself. But I met Sarah and I met Violet, and they really educated me, enlightened me about like what that word means for some people. And something that they both said is like, you know, for some people who are metastatic or stage 4, they may never call themselves survivor. And then what happens to those who don't survive? Like, did they fight any less? So to them, it was very like it wasn't an inclusive term. It was actually offensive. So, you know, I took a lot from that. And then if you actually see, there's a lot of like spaces where you see cancer patients saying that cancer survivor is not something that they relate to. So here is actually a forum. So it's like a space where cancer patients can go. It's hosted by the American Cancer Society. The name of the forum is Cancer Survivors Network, yet you will see threads upon threads where people are posting, I hate the term cancer survivor. This was this was an op-ed in the conversation. Again, similarly taking, you know, so a lot of this wisdom and bottling it up and sharing why people with diagnosed with cancer don't embrace the term survivor. So aside from popular media, there's also been research that's been done on this. So this is a study that was done among women, females diagnosed with breast cancer, where they did a survey and asked participants what they thought about the term cancer survivor. And this is just an excerpt from the conclusion. So using the blanket term survivor to label a diverse group is problematic. Although the term offers a positive identity for some patients, others reject it or find it offensive. So there's been similar studies that have been done in patients with prostate cancer, but nothing done with patients with colorectal. So I thought, this is an opportunity to lend our perspective, lend our voice to this conversation. So came the first study that I'm going to talk about, Define, which was published last year, 2021, in the Journal of Cancer Survivorship. It's a bit ironic, I know. So what was the study about? What is the circle of death? Oh, sorry. So it was a cross-sectional survey where we were able to recruit 539 patients diagnosed with colorectal cancer. And then our survey asked some quantitative questions, and we also left open text boxes where they could write their experiences and perspectives. So then we were able to apply descriptive statistics for the quantitative data and content analysis for the qualitative data. So these are some of our findings. So from the qualitative analysis, we found a spectrum of perspectives towards the term survivor, and it would range from aversion all the way to acceptance. So just to read some of the quotes. So my life is worse after cancer, therefore I do not feel as though I survived. I don't relate to the battle metaphors, the fight against cancer, survivorship. I don't want my body to be a battlefield. And then even when you go into like the more positive side of that spectrum, it's still not quite, it's not an embrace. So I hesitate to say it because it implies I'm over cancer versus currently experiencing it. It's a word that I'm stuck for the rest of my life. So in our quantitative questions, we asked participants about like preferred terms or alternative terms. And we landed at patient. And again, when I think about some of the conversations I've seen, people talk about like in diabetes or in heart disease or even arthritis, people just get called patient. So why does cancer have to have this label? So because of all this, we use the term cancer patient to refer to individuals across the care continuum. So whether that is undergoing active treatment or living beyond cancer. And I now refrain from using the word survivor because it truly is not a good representation of the cancer experience. So now I want to talk a little bit more about like the data-driven part of the research. So as an epidemiologist, I get excited by data in every form, but my training really has been with using our administrative data in BC, which we are very lucky to have. So that is a big driver of this research. But we supplement that with interviews, focus groups, and surveys to really get at the patient perspective. The patient power in this, it's not me, I'm not the patient power, it's actually the community of patients that I've been really lucky to be a part of, to be supported by. So I just have some of them listed here, but it's actually a big network of colorectal cancer organizations that I've been really fortunate to have had a chance to work with and interact with. But I really want to give shout out to Colon Town. So I'm a member of Colon Town. Also to our two leading Canadian organizations, Colorectal Cancer Canada and CRAN, Colorectal Cancer Research and Action Network, as well Young Adult Cancer Canada. And then, in the communication and the interactions and the engagement with our patient communities, I really rely a lot on social media. So through my Instagram and also through my Facebook. Some of these are private Facebook groups that I belong to, but also through Twitter. So now I want to talk a little bit about the EXPLAIN study, and particularly looking at the incidence of young onset colorectal cancer. This is now taking the big data that we have in BC and using that to explain young onset colorectal cancer. So this is the study, or this is the project, CHR project grant that we were fortunate to have a no-cost extension due to COVID to 2025. So I have three main objectives: looking at the epidemiology of young onset colorectal cancer, looking at outcomes and healthcare utilization, and I'm doing some health economic work. And the data sources are primarily Pop Data BC data that's linked with the BC Cancer Registry. I get really excited about this, this flow chart, which just shows the richness, the data linkages that we've been able to do, and also the numbers. So I know there's a lot on this slide, but the take home here is that with all these data linkages, we have rich data on a big cohort of individuals with colorectal cancer. So that's about 55,000. And then we have a 1 to 10 ratio of controls. And then among the individuals with CRC, they are divided into those with yCRC and those with average age onset. So then we have the opportunity to do an analysis, to compare experiences between young onset and average age onset. And then we could also do some comparative work, with cancer patients and cancer-free controls. So as I mentioned, one of the studies that we've been able to do is look at the incidence of young onset colorectal cancer. So there's been data in so many different jurisdictions about the increasing risk, but we really wanted to see that in the Canadian context and also in the BC context. And this is like our main findings where we confirm, what we've seen in other jurisdictions. So overall, we saw the annual percent change in incidence of young onset colorectal cancer over a 30-year period to be 1.48, which is statistically significant. And then when we look at different sub-analysis, we found that again, reflecting what people have seen in other jurisdictions, that a lot of this risk is being driven by cancers of the rectum. Another thing that we did into that study is we looked at the incidence of yCRC in 1-year increments leading up to age 50, which right now is the start of the population-based screening for CRC in Canada. And one of the curiosities for this analysis is when we were doing it in the US, they had just lowered their screening age to 45. So what we found in this analysis was we did see a steady increase in risk over time. And then there was a little bit of a blip between 49 and 50 years. So there was about a 20% increase in the risk of CRC between 49 and 50. Again, recognizing that the age of screening starts at 50. So, this paper has since been used towards conversations about the consideration of lowering the screening age for CRC in Canada. So I want to keep going, and I want to tell you about another study that we did, which is what we call STORY, just to show a little bit of the patient power and the power of social media and the power of patient communities. So the story is about, the study itself is talking about what is the experience of yCRC patients, and it was a cross-sectional survey. So the story behind it, so it was inspired by Colon Town. So this is just a great infographic, Colon Town. So it is basically a private Facebook group of patients, caregivers, supporters, healthcare providers that are dealing with colorectal cancer. And then within Colon Town, there's different communities. Again, you can join the main page, but then you can also join different neighborhoods based on the experiences that you're going through and the supports that you need. So I wanna recognize and shout out Manju George, who is a powerhouse, one of the most inspiring people I know. She was one of the administrators at Colon Town, now a scientific director. Now she is she's such an active advocate and such a big contributor to cancer outcomes research, not just for colorectal cancer, but for cancer in general. So back in March 2018, or is it March 2019, she started a post. So March is Colorectal Cancer Awareness Month. So she started a post inside Colon Town, where she asked people to share their experiences of what it was like to be diagnosed with young onset colorectal cancer as a way to raise raise awareness. And her hope was that somebody would share a story per day so that we can share these stories. So I was really amazed when, I think she posted on a Saturday, beginning of March. And I saw that post go viral, that by the middle of the day of that Saturday, people had posted so many stories that Manju met her 31 story goal. And then she started creating sets. So once 31 days were done for one set, she started on to set 2, set 3, set 4. By the time I jumped on that thread and shared my story, it was already set 4. So there's already been like 3 sets of 31 that have already shared their stories. So again, I was going in here as a patient, but then as an epidemiologist, as a researcher, I was like, oh my God, this thing just grew over like the course of 4 hours. Like we researchers would die if recruitment happened that quickly. So, and then the other thing I was thinking about is doing this inside Colon Town, when the goal is to raise awareness, you're kind of, it's that analogy of like preaching to the church or singing to the choir. Like these are already people that are hyper aware of colorectal cancer, of young onset colorectal cancer. So we really need to take this outside of the church. So I was like thinking, okay, how could we turn this into a research study? So I reached out to UBC Ethics to see how could we design a study, because again, I would have loved to have just used those threads, but people didn't join Colon Town, people didn't join that thread for research purposes. So I worked with UBC Ethics to kind of design a study that would mimic that experience. And then I also reached out to Manju at Colon Town to see if we could replicate that. And then also reached out to Erica, who is the founder of Colon Town, for her blessing. So from all of that, we designed a cross-sectional survey, and we were able to recruit 121 patients diagnosed with yCRC. So similar as defined, we use both qualitative and quantitative questions inside that survey to be able to draw from our data collection. And then what we did was, we tried to really create the study so that it looked like a post inside Colon Town, but really they were inputting the data into a Qualtrics survey. But it worked really well, and we were able to again achieve a similar high rate of recruitment because we were able to do the recruitment inside of Colon Town. So that's one of the things I was able to get approval from ethics and also from Colon Town, is that as both a member of that community, I can recruit, put the post inside the private Facebook group. So just to share some of the findings. So I'm going to share some findings that I shared actually after that. I was sharing the findings back to the community. So I did an Instagram post, and which is also like, so this is my Instagram is public. So this is what I'm sharing. I also did similar posts inside of Colon Town, but since that's a private space, I'm not able to share those, but it's essentially the same idea. So one of the questions we asked is what were symptoms ahead of the diagnosis. So this is straight up from my Instagram post. Most frequent was blood in the stool, digestion issues, changes in bowel habits, pain in the abdomen, back or legs, and so on. And then also important findings from that when we were looking at the qualitative data is themes around being misdiagnosed, themes around advocating for oneself. There was appreciation of the medical team, but also some frustration with the medical team. And then a really important theme was one on the lasting effects of yCRC treatment. So I'm just gonna read some of these. So along the theme of being misdiagnosed, I had a response about, I had a doctor tell me that my rectal bleeding, constipation, and tailbone pain was because of constipation, nothing more because I was so young. And then just a quote around the lasting effects of yCRC. All three of us suffered the lasting effects of this journey, my spouse with PTSD, my daughter with a massive fear of death and separation, and myself mentally and physically from the treatments. And another thing that came out was, related to that, mental health really came out. So mental health was a challenge throughout, as was financial stress. So, so aside from, using this, we learned so much from that study, and then how can we efficiently collect data using our patient groups. So now we can actually launch a study and be able to collect data in a month, powered by Town and all our patient networks. But I really wanted to build from those themes around mental health, from what I found in that study and what I experienced myself. So going back to explain, because we have this great data where we can interrogate this question, hot out of the oven is a study that we just published looking at mental health in young onset colorectal cancer. So again, I just love seeing data linkages. So I put this up here. It's, again, just shows the richness of our data, plus the sample size that we're able to achieve because we're using the entire population of BC. But what I want to take you through is something that I tried with this paper, because I've been seeing it for a while, is a tutorial. Because we work so hard on our research. I think we researchers need to do a better job of really pushing our research out there. So I've been seeing a lot of people do tweetorials, sorry, I can't say it, tweetorials. So I thought, oh, maybe this is a good chance for me to do a tutorial on this paper. So instead of showing you the findings, I thought I'd show you the tutorial, which is the findings. So the paper was published on May 4th. So it really is hot out of the oven. And then just coincidentally, that was during Mental Health Week. So it was a good opportunity to use that time to, again, really help amplify the message. So this is the start of my tutorial. So this is the first tweet, just talking about last week we published our paper on the risk of depression and anxiety after diagnosis of young onset colorectal cancer. And then I went along with my tweets about our main findings. So one of the main findings is compared to individuals diagnosed with average age onset. Those diagnosed at young onset have 41% increased risk of depression. So I just created these infographics using PowerPoint. I know it's not very sophisticated, but I think they work. A second finding that I wanted to highlight is when we did sex-based analysis, we found that males with young onset colorectal cancer had 76% higher risk of depression compared to males with average onset colorectal cancer. And then I also wanted to highlight that when we compared individuals with colorectal cancer with cancer-free controls, we found that the risk of depression is driven by the risk among males. So then I ended off the tutorial by tagging people so that they can hopefully amplify the message. And then because this research, again, is so personal to me, I put in my own perspective in that, like, through this time, I haven't been afraid to share about like poops, farts, all things that come out of like the behind. But I was really scared to share that this research paper meant a lot to me because I too have my own struggles with my mental health following my cancer diagnosis. So I got a lot of support about that. And again, this just shows me that when you open yourself to the world will really open itself right back at you. But I'm still a researcher. So here's some analytics. So here's some analytics that I downloaded from Twitter. So my tweetorial, I don't know if these are good, but I think 3,000 impressions is pretty good. And the number of engagements and profile visits. And then in terms of like the article metrics, so since it got published, we've had 625 abstract views and 698 full text views. So I think that's really good. And I think some of the things that have come out with that engagement is I'm now having conversations with some male cancer advocates to really try to get to that message and try to unpack, what is driving the higher risk that we see among males. So I think there's going to be a podcast coming up and some other things that we're going to keep doing to really keep the conversation going. So that basically are all the studies that I wanted to talk about. And just the last things before I finish off is just where we're going. So administrative data is great, but it lacks a lot of the context and the perspectives. So we really want to explain some of the findings that we found, particularly like the drivers of higher depression among males. So I'm really excited that I have master student Vicky, who I think is here today, Vicky, put up your virtual hand if you're there. So Vicky is a PharmD from our program who will be doing qualitative research. And we hope to launch it this summer, where we're going to be doing semi-structured interviews with patients with colorectal cancer to really try to explain the mental health experience. So stay tuned for that. And we might be asking for help with helping recruit. So maybe some retweets. Another thing that we're working on, they're currently being churned out as we speak, is the cost of yCRC. So again, I think this is to lend data to help move along the conversation about whether there is, about lowering that screening age, because I know there is a big economic component to that decision. So those data are being churned as we speak. And then another study still in development is now taking my perinatal epidemiologist's brain and looking at reproductive and sexual health in not just young onset colorectal cancer, but adolescent and young adult cancers. And just really quickly, we have done work on this area already. So one paper that we did, we looked at Reddit threads to look at what patients with cancer ask about treatment, fertility, and pregnancy. And then we did similar as story and similar as defined. I did a survey study with my community looking at reproductive health experiences among women with young onset colorectal cancer. And one of the things that I found in this work is I went in there again with a perinatal lens, but what came out was it was really hard to disentangle the sexual health from the reproductive health. So that's why moving forward, the study that we're going to be doing is using mixed methods, patient-oriented research informed by sex and gender-based analysis that looks at sexual and reproductive health together among adolescents and young adults that were diagnosed with cancer. So we have 3 aims. We're going to be doing focus groups. We're going to be leveraging administrative data in BC through Stuart, who has a big cohort of adolescent and young adult cancer patients in BC, which is the CHÉOS cohort. And then we're also going to be doing focus groups again with patients and also with healthcare providers to ask them how we could improve reproductive and sexual healthcare for AF cancer patients. And I've been standing in front of like this, this t-shirt quilt that I built. So a lot of those t-shirts that went on that quilt that I sewed, I learned how to sew during COVID, are those that were worn by friends, family, colleagues. So this was a push for your tush run right before my lower anterior resection surgery. And I still am touched about like the incredible support that people have brought during my cancer journey, even now. So guess I'm going to keep pushing for my tush. And I really thank people that have supported me and all the spaces that let me share, because I think every time I share is a chance to use research to raise awareness about young onset and colorectal cancer. And with that, I want to thank everybody. I've left lots of time for questions because I really hope to have conversations. There's my Twitter handle, my Instagram,